All right, now let's talk a little bit about the idea of systolic and diastolic dysfunction. Systolic dysfunction, let me remind you real quick. What do we do in systole? What's the heart do? It does two things: pressurizes and ejects. It pressurizes and ejects. So if I have systolic dysfunction, I will have a problem emptying the ventricle. Stated another way, I have a problem pressurizing or ejecting, but it's the ejecting that's going to be the key. I have a problem with ejection, so stroke volume is going to go down. This could be related to reduced contractility or high afterload, just as we described on the ventricular function curves. Diastolic dysfunction. Well, this is a decrease in ventricular compliance during the filling phase. So in other words, it's stiffer. It can't fill. What do we do in diastole? We depressurize and refill. We depressurize and refill. So what's going to be the big problem? The big problem in diastolic dysfunction? Well, I can't depressurize and refill. And why can't I depressurize and refill? It's because the ventricle gets stiffer. The ventricle gets stiffer. This means a diminished Frank-Starling mechanism, because remember, Frank-Starling is the link-tension relationship. It's the input-output relationship. So, systolic dysfunction, the big key we're looking for, low stroke volume, but it will also have low pressurization. I can't pressurize and I can't eject. Diastolic dysfunction, you get a stiff ventricle, which means I can't depressurize, so diastolic pressure is going to go up, and I can't refill, and diastolic volume is going to tend to go down. All right, what can cause these? Let's talk about two different ways to overload the heart. What's going to cause problems? Overloading the heart. Well, I can overload it two different ways: pressure and volume. Pressure and volume. Do you see that that's also a recurring theme in this chapter? Pressure and volume and cap. All right, what would be an example of pressure overload? Hypertension, aortic stenosis. Heart has to work harder. All right, initially it's okay. We'll increase contractility. We'll be able to deal with it. But chronically, over time, the ventricle will develop a concentric hypertrophy. All right, let's think about that. Concentric hypertrophy. This is a bad hypertrophy. All right, this is a big increase in wall thickness with a decrease in chamber diameter. Now, if you think about it, if the heart has to work, the heart's a muscle, just like skeletal muscle. You go to the gym, get yourself all pumped up, yeah. Well, skeletal muscle hypertrophies, cardiac muscle is no different. And if you give them a pressure overload, big increase in afterload, then you get this bad hypertrophy, a concentric hypertrophy. Makes that wall very thick, and I diminish chamber size. All right, thick walls are stiff. Thick walls are stiff, so what do I get? Diastolic dysfunction. Thick walls are stiff, I get diastolic dysfunction. I won't be able to depressurize and refill. Eventually, you'll get a systolic dysfunction and ventricular failure. But the hallmark traits initially for a pressure overload, as it starts to become pathologic, this concentric hypertrophy will cause a diastolic dysfunction. Thick wall, very stiff, I can't depressurize and refill. Okay, contrast pressure overload with volume overload. Examples: mitral aortic regurg, patent ductus arteriosus. If you wanted to throw in pregnancy, you could throw in pregnancy. It's just as the name implies. You're just overloading the heart, but from a volume standpoint. Pressure, volume, pressure, volume. By and large, this is pretty well tolerated if it develops slowly. However, if you get a big increase that occurs acutely, it may trigger a heart failure. Now, in response to a volume overload, you get a different type of hypertrophy. This is called eccentric hypertrophy. And in eccentric hypertrophy, there's a modest increase in wall thickness that does not reduce chamber size. So I'm not getting real stiff with a diminished chamber size. Instead, I'm getting more muscle because I'm working out, getting more muscle, but I'm not reducing chamber size. It's not a big increase in thickness. This is actually technically a good hypertrophy for the heart. This is the hypertrophy of exercise, an eccentric hypertrophy. So, because of that, that means we don't have diastolic dysfunction. But what's ultimately going to happen is systolic dysfunction. Just think about it as you're wearing the heart out. That's the way I like to think about it. You're just exercising the heart 24/7. You know, none of your muscles can deal with 24/7 exercise. Got to be able to rest in between those exercise bouts. Well, a volume overload is like 24/7 being at the gym. I mean, 24/7 you're running on you can't run on a treadmill 24/7. Nobody can. Or a bike or swim or anything. So the heart's the same way. So ultimately what will happen is you will get systolic dysfunction if you have a volume overload for a sufficient period of time. When a heart gets dilated, one of the things to look for on step 1 is this idea of the law of Laplace. Here we've rearranged the law of Laplace to tell us that pressure equals tension over radius. All right? This greater radius means I have to generate a greater wall tension in order to get the same ventricular pressure. So there's a big time wall stress, and that's the thing to look for on step 1. If you get a dilated heart, you have a lot of wall tension or wall stress. And this relates to law of Laplace. We will see law of Laplace again when we talk about cardiovascular. All right, to end this chapter, let's talk about the cardiomyopathies. This is a failure of the myocardium where the underlying cause originates within the myocytes. We're going to have 3 basic types: dilated, restrictive, and hypertrophic cardiomyopathy. By and large, the names pretty much fit with what's going to happen. All right, here we have a picture, normal heart to the left, and to the right we have what's called a dilated cardiomyopathy. So, bottom line, just as the name says, we have a dilated heart. Notice the ventricular chamber is much bigger, and there's only a modest hypertrophy. Because we have a nice chamber size, big chamber size, we can depressurize and refill. Therefore, diastolic function is intact. There is some compensatory increase in systolic function because we will activate the sympathetics, because we're actually going to have a reduced output. So in other words, systolic dysfunction. The heart is dilating because we can't eject well. All right, the heart is dilating because we can't eject well. So that's what's going on in a dilated cardiomyopathy. Over time, the heart can dilate so much that you'll ultimately get mitral and tricuspid failure, which will then cause even more systolic dysfunction. And this is because the heart's stretching out, and it's just going to pull open. It's going to pull open those valves. Basically, you get a regurg. You get a mitral and tricuspid regurg because of this stretching out. The heart is dilated out. All right? Hence the term dilated cardiomyopathy. Now, let's think about this. Do we remember our pathology? Can you give me some causes of dilated cardiomyopathy? Think about it. Integrate. Think. Integrate. Yeah, if you said idiopathic, excellent. That's the most common cause, idiopathic. But I know I heard a lot of cocaine, alcohol, doxorubicin, Chagas. Very good, very good. And there are more. I'll let you look in your pathology book to remind yourself. But those are some of the more common causes of a dilated cardiomyopathy. Going effectively the exact opposite direction is a restrictive cardiomyopathy. Here, the ventricle is restricted from filling. So, decreased ventricular compliance, it's stiffer, so I have diastolic dysfunction. Diastolic dysfunction. The heart is restricted from filling up. Okay? Can't depressurize, can't refill. So we're going to have elevated levels of filling pressure, which could cause congestion on the left and right side. Even if it begins on the left, can ultimately cause right side congestion. The problem with left side congestion, hopefully it's just quickly snapped into your head. Left side congestion, so in other words, congestion of the left ventricle and what's behind that, that's pulmonary veins, pulmonary capillaries that can cause pulmonary edema. May or may not have hypertrophy, that is not required. By and large, at least early on, systolic function will be pretty close to normal. The problem is I can't fill, I can't depressurize and refill. Now, pathology, can you remember? What causes restrictive cardiomyopathies? Oh, very good. The OCs. Amyloidosis, sarcoidosis, hemochromatosis. Beautiful job, beautiful job. Always try to think, always try to integrate, work them together. The last form of cardiomyopathy is called a hypertrophic cardiomyopathy. Now, this one's going to be a little bit different than the restrictive because we are going to get hypertrophy. And this won't really be an eccentric or concentric. It's actually going to be more like a concentric. But you'll get septal hypertrophy. And I want to highlight that word septal hypertrophy. Okay? This septal hypertrophy is one of the hallmark traits of this. Also, the other hallmark trait is we've got septal and ventricular hypertrophy, but it's not related to a pressure overload. You know, it's not an increase in afterload that caused this hypertrophy. That is not what caused it. Now I've got a hypertrophy, I've got a thickened wall, smaller chamber, diastolic dysfunction. It is stiff, it can't relax, it can't depressurize and refill. Oftentimes you will see what's referred to as a disarray in the septal fibers. And that's another going to be a key one. If they give you that on step 1, oh yeah, just jump all over that. Jump all over that. Now, you can also get an hypertrophic obstructive cardiomyopathy. That's what HOCM stands for. And this is because we call this an outflow obstruction because the aortic valve and just distal to the aorta gets compressed by this hypertrophied septum. And so there's a restriction in the ability to eject blood. So that's what's meant by hypertrophic obstructive cardiomyopathy. There's a restriction in ventricular outflow tract. Particularly like aorta. Yeah, aorta is one of our ventricular outflow tracts. All right, pathology on this. What's the big one to look for here on step 1? Yeah, sudden cardiac death in athletes. This is classic clinical vignette for you. You know, 17-year-old or 21-year-old suddenly dies who's an athlete. You're thinking hypertrophic cardiomyopathy. Now we're getting much better with ultrasound. We can see these, we can diagnose these, we can see them before we get to that point of sudden cardiac death. This is big time related to genetics. Genetics is a key player here.